Hello everyone. In this lecture, I am going to discuss the predictive test in preeclampsia. So there is no single biological marker is there that if the particular value is increasing, then only you can say that the woman is having this disorder. It is not like that. Whereas you need to perform certain tests to confirm this disorder, as this is affecting many organs in a woman at the same time. So we have discussed about this, that it is a multisystem disorder, right? So in this what happened, there is an increase in blood pressure, right? So how much it is increasing? It is increasing about more than equal to 140 by 90 mm of Hg. So when the blood pressure is increasing for about at least 2 times on 2 separate occasions, that could be at least 4 to 6 hours apart, but when it is to be appear first after 20 weeks of gestation, right? So along with that, there is a significant proteinuria is also there, right? So let's see, by involving the major organ, what all tests we need to do to confirm this disorder, right? So as we know that the organ which is affecting is the most is the kidney. So we can perform renal function test. So in this disorder what happened, there is an endothelial dysfunction, and because of that the glomerular lining is also damaging, right? So because of this damage, the protein is leak out through the urine, right? But here, because of this vasospasm, the filtration is decreases because the flow is also decreasing, right? So there is a oliguria in a woman, but along with that the protein is leaking more. And which type of protein is more leaking? There is albumin, right? So there is a proteinuria. So how we can identify proteinuria? By the urine sample. So with the urine sample we can rule out the microalbuminuria, that is excess loss of albumin, that is a type of protein in the urine. So if there is a loss of more than or equal to 300 milligram in 24 hours urine collection, right? If we are collecting urine for at least 24 hours, then there could be a loss of more than 300 or equal to 300 milligram, right? Or you can confirm it by the dipstick method if we are getting +1 reading or more than that. So what +1 stands for? Here, when the urine loss is more than equal to 0.3 gram in each liter, right? Or you can confirm it by the protein creatinine ratio, PCR, that is, if it is to be more than equal to 0.3 milligram per deciliter, then also we can say that the woman is having significant proteinuria. Now, the another finding after this proteinuria is the increase in uric acid level in blood, and that is called as hyperuricemia. So we know that there is a damage in the glomerular lining and there is a swollen glomeruli, and because of that the waste like uric acid is not able to comes out with this urine. So it remain high in the blood, right? So in many of the book it is considered that it is one of the biochemical marker in this proteinuria if the uric acid level in the blood remain high, right? Now after this kidney, the other organ which is involving is the liver. So we can perform the liver function test. So we know that because of this vasospasm as well as endothelial dysfunction, the cells of liver is damaging, there is a necrosis, there is a ischemia, as well as there is a thrombosis in arterioles. So that all may lead into the elevated liver enzymes. So the enzymes which are elevating are the AST and the ALT, that is aspartate transaminase or alanine transaminase, that is SGOT or SGPT, these are the other names. So the level of these enzymes remain high, and these are just double the fold of their higher limit. So there may be an increase in more than 70 international unit per liter, right? The next is there is a destruction of RBCs, right? So there is a hemolysis. So because of this, there is increase in bilirubin production as well. So we can also check out the bilirubin level, and because of this all necrosis, there is again increase in LDH, that is lactate dehydrogenase, right? So this was about the liver function test. Now after that, on the basis of their basic pathogenesis, that is the endothelial dysfunction, as well as because and why it is happening, because of the oxidative stress. So because of this oxidative stress which is causing the endothelial dysfunction, what all tests we can perform? Because of this damage, we can see that there is an increase in RBCs. So we know that once the endothelial lining is damaging, the fluid is leak out into the interstitial spaces, and there is increase in RBC count. Because of this, the woman may have hemoconcentration, right? So as the hemoconcentration occurs, we can rule out the hematocrit value. So there is an increase in hematocrit value because RBC is more in compared to the total blood volume. So there is an increase in hematocrit value, but there is decrease in platelet count. So platelet counts are decreasing. That is, there is a thrombocytopenia. That the platelets are decreasing about less than 1 lakh per cubic millimeter, or you can say the microliter. So why platelets are decreasing? Because there is a endothelial dysfunction and there is a damage. So because of this damage, the platelets are consuming, these are used up. So because of that, the circulating platelet count is decreasing. So there will be a thrombocytopenia or decrease in platelet count. Now we know that the problem in this whole pathogenesis of this preeclampsia is begin in the placental area. So on the basis of the placental defective invasion and the change in the vascular resistance, which test we can perform? There is one rollover test. So by this test, when we are giving any stimulus, there is an increase in blood pressure. And what stimuli we are giving here? We are changing the position of woman. So first we ask a woman to lie down in a left lateral position, and we monitor the blood pressure of a woman. And after that, we just realign a woman in a supine position, and once again we check the blood pressure. So we find that there is an increase in blood pressure with this changing of position. So this is called the rollover test. But this is not the confirmatory one, that after this changing position we can predict that the woman is having 100% preeclampsia. So to confirm this, we have Doppler USG. So in Doppler USG we can perform uterine artery Doppler velocimetry. So by this Doppler USG, what we can find out? We can rule out the resistance in the arterioles, right? Because in the pathophysiology we have seen there is a defect in the spiral arterioles remodeling during second trimester, right? If you recall that the trophoblastic cells are not invading up to this decidual myometrial junction in the second trimester, and that's why the spiral arterioles remain narrower. And by this reason only, what is happening? The flow is decreases and the resistance is high. So by these images we can rule out that there is a systolic waveform and there is a diastolic waveform, but in between these systolic and diastolic waveform there is a diastolic notch, right? and this diastolic notch is representing the slower velocity. There is a slow flow, right, in between the systolic as well as just before the maximum diastolic flow, right. So by this diastolic notch we can confirm that there is a slow flow of the blood, right, which is happening in this pathogenesis of preeclampsia, right. So here it is the systolic waveform and here it is the diastolic. So you can see here there is the diastolic notch and that is indicating the flow is slow, right. So in this video we have seen what all combination of tests we can use depending on the organs which all are involving. So if the liver is involving so extensively, then we can also go for CT scan and MRI, and we can rule out if there is subcapsular hematoma formation is there, and if cerebrum is involving, then also we can use these imaging studies, right. Thank you.